Good morning, ladies and gentlemen. My name is George Akwamenta. I am an associate, I'm a professor of pharmaceutical sciences at the Massachusetts College of Pharmacy and Health Sciences. I'm president of the Convention of Biomedical Research, Ghana. We'll continue with our series on on SARS coronavirus 2. Or COVID-19, that's the name of the disease. We started on Tuesday. We had a very good session. We had Dr. Michael Owusu from KCCR, and we had Dr. Henry Bonney from Saudi Arabia present their work on SARS and on virology generally. So that was very insightful. We'll continue today. We have two experts lined up to give us another exciting session today. Before we begin, I'd like to acknowledge some of those who have worked behind the scenes to make this possible. I would like to recognize Dr. Nanaba Pepra from the KNUST, Dr. Kwesi Ayamfo from University of Cape Coast, Professor Winfred Amaku, and members of the board, Max Anani Akolo, Emmanuel Adabo, Kwejo Asamoah Kusi, Tomisin Afolayan, Lorraine Ansa, Imoru Ibrahima, Anthony Efumeje, Francis Zoto, and I'm hoping I didn't leave out anybody, but thank you all so much. And this morning, it is my pleasure to introduce to you Dr. Joseph Humphrey Kofi Bonney. He's a virologist and senior research fellow at the Noguchi Memorial Institute for Medical Research at the University of Ghana. Dr. Bonney has received numerous grants and awards, has a strong publication record. It's currently funded through the Montana State University by the U.S. Defense Advanced Research Projects Agency. He is working on a project to preventing emergence and spillover of bat viruses in global hotspots. It was very germane to the discussion this morning. He's also funded by the Japan Agency for Medical Research and Development and is currently working on molecular epidemiology of dengue fever and chikungunya viruses in Ghana. So ladies and gentlemen, without further ado, it's my pleasure to introduce Dr. Kofi Bonney. So Dr. Bonney, the floor is yours.
Thank you very much, Dr. George Akwamenta, for the nice introduction. And I also have to thank you for the opportunity, and not only you, to all the other organizers for giving me such a wonderful opportunity to again let the world know more about what is happening with regards to the COVID-19 pandemic that we are having currently to deal with. And to start with, I have to say that it's been 3 months of very stressful time for some of us here, because we are leading a lot of teams here trying to do the testing for the COVID-19. And as you might have seen, I mean, from the data circulating, I mean, Ghana is one of the African countries that is leading in testing. And where I find myself, that is Noguchi, is one of the leading testing centers in the country. And I'm leading one of the teams to do the testing. Yes, to the substantive topic. Yes, I would say that, yes, we have had this COVID since we started having it worldwide. I mean, COVID-19, December 2019 occurred in China, Wuhan to be specific, as cases of pneumonia and later on diagnosed or were able to detect the COVID or SARS-2 coronavirus. Coronaviruses, as we know it, has been with us for some time now, but for this particular coronavirus disease in 2019, now we have come to know that it's a special or a new strain, a novel virus. We are learning every day, learning new things about it. It started, as we are all aware. Initially, we got to know that it is transmitted by a droplet infection, among others. But with time, or after some 2 or 3 months, we have gotten to know that now the virus can stay in the air for some time. So now we are forced to be wearing things like face masks constantly and all that. Doesn't mean it's airborne totally. Yes, our research is still ongoing to elucidate that. Not clear, but clearly we are seeing the way it's widespread, or the way it spreads so fast, so contagious. So many questions have been asked. We have learned a lot over the few months that we have contended with this. But the question is, what we have learned so far about the virus, is medical science in a position to say that we have a lot of armory now to face this scourge? I've gone through a lot of literature, and it is difficult to say, because if you look at the origin and what led to this, or the facts that we have read so far about it, we seem to get more information every now and then. In fact, things like even being present in feces is something that we find it difficult to understand. Yes, we know that for coronaviruses, some of the symptoms could be diarrhea, which is kind of rare, but yes, it's there. We have had literature that supports that. But clearly, we have seen that this COVID-19, if we are testing individuals, they test positive, and after 14 days, we go in again to test, and they have a negative report for the first time. After about a week, we test again. We don't only take a swab, that is a throat swab or a nasal swab or nasal aspirate, but we then have to also take a stool sample to make sure that clearly the virus has been cleared before we can talk
Dr.
about
Bonney, that there's been a
the patient
request.
is free of the virus.
There's been a request for you to speak up a little louder.
Hello,
if you will. This is
okay.
Dr. Kwame. If you can speak a little louder. There's a participant who is asking for
Sorry.
the voice to be raised a little bit. Yeah.
Yeah. Is it any better now?
I think so. I think it's better.
Yes. So with the substantive question that I was asking myself, it's so difficult for us to clearly say that medical science has now come to grips with this virus for us to say that we can clearly face it squarely. It's difficult, but what it means is that we are still learning about it. We are still learning a lot about it. So we don't have clear evidence. We don't have clear facts, or we don't have empirical data to say that no, we can now face this virus squarely and maybe have all the armory, be it antivirals or even vaccines, to get rid of this, or to get us safe, or to get us free. So we are still struggling. We are still struggling to go through this. And I think with time, we will come to it. Yes, we are talking about vaccines here. Vaccines, it has to go through a long stretch of phases for us to be able to talk about its efficacy and also its potency for human consumption. But yes, we can still talk about experimental ones that can really come in handy in times like that. But with all that, we have still not been able to come up clearly with a vaccine that can help. And every now and then we see how this is spreading. Now it's clear that we are saying that we are going to live with this virus for a long time. Does it mean that we have lost the fight against the virus? I'm not sure. So I can go on and on, but I want to pause here that when questions come up, maybe more of the things that I've put down, I'll be able to speak on it.
All right. Thank you very much, Dr. Bonney. Thanks for your introducing the topic. We will go on. Before we get to the point where we do question and answers, we'll have our second presenter also do a presentation, and then the floor will be open for more questions. Given what was said on Tuesday and what will be said today. All right, so let me, it's also my pleasure to introduce to you Dr. Sascha Beutler. Dr. Sascha Beutler is a doctor, has both an MD and a PhD. Dr. Beutler got her medical training from the Hanover Medical School in Germany. Dr. Beutler did her residency at Brigham and Women's Hospital and also trained as a fellow at Massachusetts General Hospital. So these are some of the leading hospitals in the world. Dr. Beutler is board certified in anesthesiology and critical care medicine. She's an assistant professor at Harvard Medical School, and she's the associate program director at the Department of Anesthesiology at Brigham and Women's Hospital in Boston, Massachusetts. So without further ado, ladies and gentlemen, Dr. Beutler.
Yeah, good morning. Thank you very much for the kind introduction, and thanks to Dr. Bonney for laying the ground of what we're dealing with. So I will attempt to share my screen to get to my slides here in a second. Let me see to bring this up. Are you able to see the slides?
Yes. Yes, we have it.
Excellent. Yes, so thank you very much for inviting me to participate today in this online meeting. As Dr. Aquamensa said, my name is Sascha Beutler and I'm an anesthesiologist. So our specialty really has been at the forefront of this disease since we taking care of all acutely ill and severely ill patients in the hospital. I'm also responsible for the training of physicians at the Harvard institutions who are heading into our specialty. And so I would like today to share with you, my preliminary thoughts and experience as a clinician at the front line. These are preliminary thoughts, and the crisis is still unfolding, as Dr. Bonney alluded to. So we are in for the long haul, and I'm sure our strategies will evolve as we learn more about the disease and its potential treatments. So please take it with a grain of salt what I'm saying today, because I'm sure my thoughts will evolve over time with increased knowledge. So last time I spoke at a corporate meeting is almost 2 years ago, and I spoke about patient safety. Now this is my first slide from 2 years ago. I shared with the audience the goal we physicians have. Our main goal is to provide safe patient care. Now, since the pandemic started, a lot has changed, as we all know. Dr. Bonney put it nicely. It's been 3 months of a lot of stress on all of us, not only healthcare providers. So this is a slide actually taken off the website of Johns Hopkins University, which keeps track of the reported cases worldwide. So not only this has changed, but the priorities as a physician when treating our patients has shifted. And at times these priorities now are competing. So on one hand, our goal is still to provide patients with the best possible care. However, at the same time, we are now charged with also keeping all staff and their families safe. So from the cleaning personnel to the attending physician. And that is quite a burden on all of us. So what I would like to go over with you today, this is a quick outline. First, a few things about COVID-19. We'll discuss risk factors, presentation and diagnosis, precautions, the disease course, what we've learned so far, as well as current treatment strategies. Then I will remind all of us that patients still need to be treated for all the other illnesses that they come with, and that we need to keep the capacity available to treat all these other patients. And then we will also touch upon the protection that we need to have in place for our frontline workers. So let me start off with risk factors for patients to develop adverse outcomes. So it's still controversial, and Dr. Bonney probably will have additional thoughts on this. But from the clinical environment, we are suspecting that the viral load is playing a big part in potential bad outcomes. We have seen worldwide that some of the first physicians who got the disease in a very severe form have been eye doctors and ENT surgeons. Now, this is easily explained or hypothesized by those physicians being very close to the oropharynx of patients. So we believe as clinicians at this point that the amount of virus particles transmitted has an impact on the severity of the disease. Then we know based on statistics that age goes against the patient. After age 60, the chances of severe disease and death are going rapidly up. Now, depending on the country, in the 70s to 80s, your chances of dying even with the best possible care available goes up to around 30%. Then we also know that certain comorbidities, such as diabetes, hypertension, cardiovascular disease, and chronic obstructive pulmonary disease put you in a higher risk group, as well as being of male gender. And then last but not least, there's been a lot of discussion around genetics. To my knowledge, we don't have data on that yet, but in the hospitals, we do have seen that in some families, sometimes a whole group of patients from one family has gotten surprisingly severe disease, even in the younger age groups. So what do the patients typically present with if they develop symptoms? And remember, and we'll talk about that too, many remain asymptomatic. So typical symptoms in 60 to 80% is they present with cough. And half of the patient upon presentation, they also have fever combined with the cough, or they will develop fever in the majority of cases during the illness. They also often frequently have dyspnea, and 20 or 40% of cases upon presentation, and additional 15% present with other upper respiratory symptoms, one of which has been discussed also is the loss of smell. So a patient who presents with a loss of smell, that's a rare symptoms amongst patients, points to the COVID-19 disease. And then, as Dr. Bonney mentioned, there is about 10% of patients who present with gastrointestinal symptoms such as diarrhea or abdominal pain. Now, remember, many infected patients or people are never symptomatic. And this is important because especially in young populations, and there is one publication that's has quite a big number of patients included, is from Vietnam. So Vietnam, obviously close to China, started closing the borders very early in January and ramped up their testing within a very short period of time. And of the population that was tested, 40% of those were tested positive but had no symptoms. So depending on the patient population, you may have a lot of asymptomatic carriers. Dr. Bonney is the expert, so I'm almost hesitant to bring up the next two slides on this, but COVID-19 tests are evolving as we speak. And to my understanding, there is no established reference standard yet. This is my citation reference is from the Annals of Internal Medicine from mid-April, a review on this topic. And part of the problem is that our understanding of the viral dynamics across the time course of the infection remains incomplete. So therefore, it is very difficult to make a rigorous assessment of the diagnostic accuracy. As you see in this slide, and that's from the publication, especially during the screening phase and or the asymptomatic phase, all of these assays have either an unknown or insufficient negative predictive value. So we don't know whether they're helpful. When a patient is symptomatic, they seem to do better, become more reliable. But then again, and Dr. Kofi mentioned it, we're also looking into when can we de-isolate a patient? When has a patient recovered? And again, these assays do not tell us yet whether a patient is in a convalescence phase and we can de-isolate them. So unfortunately, we cannot rely yet on testing. So I call it the Wuhan approach. So what did they do when the pandemic started? Patients came into the hospital, presented with at least some of the clinical symptoms that I shared. Once a patient with such symptoms came to the hospital, ruled out first influenza, and then they put them through a CT scan of the lungs, because the CT scans have typical appearance even at the beginning of the disease. Then they did apply a COVID test with the caveats we just discussed. And then taking all these results together, they made the judgment call whether they thought the patient was likely to have COVID-19. If so, they would send them to basically an isolation tent or housing, and that's where those patients would be kept for the next 1 to 2 weeks. Those who would deteriorate would be admitted to a higher intensity care wards and intensive care units. So isolation played a big role in fighting COVID-19 in Wuhan. This brings me to the precautions we have to discuss. So the first one is isolating patients. Now this is very difficult ideally, of course, you could say in a single room, but that's typically not possible. So you have to develop wards with only COVID-19 patients. Also very difficult for the patient, the families, and the healthcare providers is you need to restrict visitors. Because if you have people from the outside coming in and out, they're likely to get infected their way and bring it back to the communities. That is a huge strain on the patient's well-being as well as the healthcare workers, because now they're the only contact for the patients. Dr. Bonney briefly mentioned the type of precautions, and you can also review the CDC website. We have thought about needing droplet precautions for all interactions. Droplet precautions include a face mask and ideally a face shield. And then obviously gloves and gowns. All of that is not easy to come by, and we'll talk about that later, and I'll share with you how that has panned out here in Boston and the US. And then hand hygiene is one of the key pillars. So washing hands with soap for at least 20 seconds is tremendously important after any contact. Or with alcohol-containing hand gels, which also have become in very short supply here in the US, so soap and water is what we need to use. However, there are circumstances under which we know that even these precautions will not stop a transmission. And those circumstances are thought of being aerosolizing procedures. Now, this can be procedures, and Dr. Bonney mentioned that we've learned that the virus may just stay in the air. Now, if the oropharynx, so the mouth and nose area of a patient is manipulated, these particles become even smaller, and this is called aerosolizing. This is during intubation, extubation, and also non-invasive positive pressure ventilation, as well as when we suction the oropharynx of a patient. Under those circumstances, we need to use what's called airborne precautions. Now, mainly it's similar to the ones I mentioned before. However, the type of mask that you need to use to protect yourself from transmission is different. Those masks are called N95 masks. And they must be fitted to the anatomy of your face so that you actually have a very tight fit. Otherwise, they do not fulfill their function. Now, N95 masks have been in extremely short supply here in the US and around the world. So it may be very difficult to come by those masks. There have been many attempts made and not proven yet whether that's possible to re-sterilize them. But it's not clear if they maintain their function, if there are any downsides of doing that. Like in the hospital I work now, they get re-sterilized and redistributed, but we healthcare workers are a little bit wary about that situation because we have no proof that this is safe to do. But just to share with you, and I will share more about our situation here, it is surprisingly, has been surprisingly difficult to come by these types of equipments even here. So this just quick overview over the precautions. This is from the CDC website that points out this is what I described as the droplet precaution with a regular face mask. And really, ideally, we all should have a N95 mask that actually are fitted to the face and therefore would protect us from even smaller viral particles. But again, even gowns, surgical masks, face shield have been rationed here in Boston. And so I can't even imagine how it might look for you in Ghana to come by this equipment. So now I take the next step to come back to the patient. Now, the leading symptom in this disease has been hypoxemia. So not surprising, it's a respiratory virus and it causes lung injury. Now the question has been raised, what is causing this hypoxemia? And at this point, we clinicians think that it's likely to be multifactorial. So in the first 1 or 2 weeks of the disease, where patients present with moderate to severe hypoxemia, but often still with only a moderate work of breathing, we think that the leading cause for this is what we call a dysregulation of pulmonary perfusion. And then when more inflammation sets in, we'll observe, we think on pathology slides, it's been noted that there are many pulmonary microthrombi that develop in the pulmonary vasculature. And in the more end stage of the disease, those who will die, we see pulmonary edema in a similar fashion as we've seen for years been described in ARDS, which is the acute respiratory distress syndrome that we're all very familiar with in the clinical arena. So again, as a summary, we believe that this is multifactorial and evolves throughout the disease course. So important to realize, and that's been only learned since over the last 3 months, really since January, maybe 4 months, that COVID-19 pneumonitis is different from the acute respiratory distress syndrome that we are as intensivists and clinicians are familiar with. It does not fit the classical definition or presentation. So in the acute respiratory distress syndrome, it's often within the first week that patients' lungs become very stiff, so they have a low compliance, and we have a challenge with hypoxemia. In COVID-19, we see for a long time lungs with almost near normal compliance, which we are not, but also, on the other hand, severe hypoxemia. So we're dealing with a different lung injury than the acute respiratory distress syndrome. Dr. Gattinoni, who is very well known in the world of pulmonologists and anesthesiologists, he's Italian, so this is from a publication in intensive care medicine that's online available ahead of breath, has described it as 2 phenotypes that we are seeing clinically. So the phenotype L, I basically just described it to you. L stands actually for low everything. It's caused, as we think, by a dysregulation of pulmonary perfusion. So we have normal compliance of the lungs. We have a low lung weight, and one intervention that we're used to do when a patient is hypoxemic, increasing the positive inspiratory pressure, is very limited in the response in these patients. So we're left with, and I will come to this next, with our treatment strategies, mainly with providing more oxygen, but we can't recruit the lungs like we do in what we in ARDS. So that is, again, as from Dr. Gattinoni, the phenotype H that we're more familiar with, the ARDS type, where we see pulmonary edema and a collapse of the lungs. So coming back to COVID-19, in the first 2-3 weeks, we see the phenotype L in most patients. We can provide more oxygen to them, either via nasal cannula or face mask or a non-rebreather. We have learned over the last 3 months that one other intervention can be extremely helpful, And I encourage, because it's also cheap, you turn the patient on the belly while they are spontaneously breathing. So these are patients that are hypoxemic, they have difficulties oxygenating. You give them oxygen in any form that you have available, and then you turn them on the belly. If necessary, 16 hours a day and just a short period of time back to the back. Now, sometimes they need a lot of help with turning because they're very marginal, they're close to intubation, but with some coaching, they will understand that this may give them the chance to stay away from a ventilator. So proning awake, spontaneously breathing patients with additional oxygen is one of the measures that we should do, and hopefully avoid intubation, and therefore get them through the phase of severe hypoxemia and increased work of breathing. And then what we have done, and many hospitals actually around the world have done, they plan for early intubations to avoid emergence situations. And this has been mainly to protect staff, because whenever you're in a very rushed situation, you're more likely not to put your precautions on in an appropriate manner, and the chances of getting staff infected, especially with high viral loads, goes tremendously up. So we have for many weeks made the decision to intubate these patients relatively early. And I will tell you about the potential downsides of this approach, but the clear upside is to protect staff. So I touched upon the ventilation strategies. Near normal compliance means that we have no problem ventilating CO2 off. It's of often very little value to increase the PEEP. So the PEEP, which those who are clinicians amongst you are familiar with, we often set at 5 millimeters of mercury. Here we can go up, but we don't go up a whole lot, just to 10 millimeters of mercury, because it just doesn't help. We rather go up on the inspired oxygen level that we provide to the patient. And then even ventilated patient, or especially ventilated patient, we do prone. As you can imagine, that is extremely staff intense. These patients are on the ventilator, they have lines, they're connecting to all kinds of tubing. And so it often requires 4 to 6 healthcare workers to turn a patient, to make the turn from the back to the prone position. However, often the only thing we have been left with to do for them. And then throughout the disease course, it appears that the L phenotype transitions frequently to an H phenotype. And we think that can maybe either due to the evolution of the disease, but we also worry that we actually might cause additional lung injury due to the ventilation. So we are not sure whether this is partly induced by patients on the ventilator or if it's due to the evolution of the disease. Now this has made us reconsider our early intubation guidelines, but it is a balance act between avoiding very emergent situation where the patient's saturation is so low that we think there will be arresting, versus doing those intubations under less rushed circumstances. And then once in both phenotypes, we might come to the point that the hypoxemia is so refractory that we have to consider ECMO. Now, ECMO is only available in a few centers, even the US or Europe. It's an extracorporeal membrane oxygenation device. And so my suspicion is that it's probably not available in Ghana. It's also never been shown to make a difference even in other diseases for most patients. but ECMO has been applied in this patient population because basically the lung function is taken over by the machine. So the machine can oxygenate the blood of the patient. And we also have put patients on the ECMO, especially young patients, where we are more hopeful that they have a chance to recover. So what are the outcomes so far that we know of in the US? There's one publication from New York City. As you all know, they were in particular hard hit. About 75 of ventilated patients there have died. Now, of course, it always depends who gets even a ventilator. There's been a lot of discussion at the time how to best make a decision because there were not enough ventilators. And so the death rate of patients who are ventilated may also depend who even got the ventilator. In our hospital, our data are not complete, but from what we have gathered, it's probably about half of the patients who get ventilated who will die. But the lungs are really not the only organ system affected by COVID-19. All organs are involved to different degrees. We think that is due to what we call a cytokine storm and inflammation. The knowledge is evolving. The coagulation system is in particular hard hit in the body. These patients are prone to clotting. We have seen frequently that lines clot off, like arterial lines, hemodialysis lines, central lines. That is unusual. In a regular patient who doesn't have a clotting disorder at baseline, we would not see lines clotting off. In these patients, we have frequently seen that lines are clotted off. So hospitals and physicians have tried to different anticoagulation medications. We have in our hospital chosen enoxaparin in higher dosing, 40 milligram BID. And the reason was to avoid heparin drips. Heparin drips have to be adjusted frequently. If you use them, you have to have staff going in and out of the rooms frequently. So in order to avoid that, we have used enoxaparin. The judgment is out on which type of anticoagulation medication we should use for these patients, but it is certainly a significant problem. The other surprising thing we have seen, or maybe not surprising, is, but many of these patients went into acute kidney failure and required hemodialysis. So our colleagues from nephrology have been the other specialty really hard hit in the sense that they didn't even have capacity, neither for placing hemodialysis lines nor doing the consults on these patients and starting them on hemodialysis. Even hemodialysis machines were not available to the extent that we needed them. The cardiovascular system, on the other hand, the patients have been surprisingly hemodynamically stable in our patient population. That has not been a major problem. We have only had to use pressors occasionally and in low doses. So in comparison to other ICU patients, that's been surprisingly positive. Now we have seen troponin leaks. Troponin leaks, it's a component that comes from the myocardium. And we think we're seeing this as a result of myocardial injury due to the cytokine storm. However, patients do take often sudden turns to the worst and go into arrest. This happens typically several weeks into the ICU course. It's very unpredictable who will all of a sudden go into the arrest. We have not been able to get these patients back. So despite going through CPR and everything, those patients, once they go into arrest, we haven't been able to resuscitate them in the vast, vast majority of cases. But until that moment, we have not seen a lot of hemodynamic instability. This is a slide from Dr. Camparotto, and I want to also point you to the European Society of Intensive Care Medicine, who have a lot of freely available webinars that I found very helpful. And Dr. Camparotto has described the disease course and the late failures that I just mentioned. So there are a small group of patients who come to the hospital in a hyperacute state. They're severely hypoxic, they're severely breathless, and they require immediate intubation. But that's really the smaller portion of patients that we've been seeing. The vast majority of patients who become symptomatic and have risk factors, they develop moderate to severe hypoxemia. They get admitted to the observational wards. They're provided with oxygen. They show moderate work of breathing. And now you observe them for a week, for 10 days. And that's after that time period of a week, 10 days is when the disease course almost declares itself, whether the patient will get better or whether the patient now will deteriorate. So often there is this window of 7 to 10 days where everyone thinks, oh, it's not that bad, looks pretty okay, patient is stable, patient will recover. But then there are some of them who take that turn to the worse and we think that's the body response to the disease, and their respiratory function gets much worse. Their x-rays and CT scans are much worse, and they require intubation. They're on the ventilator, and we have a hard time turning the course of the disease around. So are there any other therapies available? And Dr. Aquamensa is probably the expert on this, so I hope to hear from him maybe a few comments. Everything at this point is under investigation. Now, we've heard a lot about remdesivir that has first promising results at any point of the disease course. However, few caveats, these are very early results on small patient population, and also simply the medication is not widely available. In the US, discharges have been distributed to the State Department of Public Health, which then distributes it to different tertiary care centers, all as part of studies, and all not sufficient for every patient to get it, just for a few selected ones. Then chloroquine, as you know, thanks to our dear president, has been on the horizon. And so as of 2 days ago, all trials with chloroquine and chloroquine combinations have been put on hold by the World Health Organization, because there has been data that these patients have worse outcome. So that death rate has increased if they were treated with chloroquine, hydrochloroquine, or chloroquine with other medications. So please do not take chloroquine or overdose on chloroquine, and you can cause cardiac arrhythmias in your patients or yourself and have an early death. Another medication that's been talked about is an interleukin-6 blocker. It's also investigated in trials. And then there are many combination therapies currently under investigation. I just listed one. It's interferon plus ribavirin plus lopinavir and ritonavir. There are some promising signs, but of course, all of these medications come with potential downsides. So really, even in Boston, when we treat these patients, we may get remdesivir for some very severe cases as part of the trials, but nothing else is available at this point. another overview slide which correlates the disease course that we've talked about with potential interventions. It's a busy slide, but it just basically summarizes what we've talked about. So now let me come back to the beginning of my talk, but also back to the beginning of what we physicians, what our goal is in our daily care for patients. I mentioned, I want to emphasize this, we do have to remember their patients are still suffering from all other kinds of diseases which require our care. So it is very important that we restructure our workflow and that we maintain the capacity to take care for patients with other illnesses. And this is a true challenge. So we need to separate wards, we need to separate ED admissions, we need to separate intensive care unit for non-COVID and COVID positive patients. And we simply need to maintain the capacity of our personnel. And as I mentioned earlier, taking care of COVID-19 patients is very staff intense. So we need to plan ahead to keep staff for all the other patients. That we also need to encourage to still seek our help in the hospital, because otherwise they will suffer adverse outcomes. And we already have data that patients will not come to the hospital because they're so worried about acquiring COVID-19 that they stay at home having a stroke, they stay at home with heart attacks, they stay at home with burst appendicitis, etc., etc. So therefore, we also need to maintain the trust of our patient. And this is only possible with transparent and clear communication. We need to state our limitations. We need to explain what we are doing and why. Without that, we cannot maintain trust, and we will create bad outcomes in patients with other diseases. And what is so different in this pandemic? I said it very early on, it is an absolute necessity that we think about all of the frontline workers. And these are all those who work in the hospitals or care homes. It's the cleaners, it's the nursing assistant, it's the person working in the morgue. All of them are worried about their own health and the well-being of their families. And none of us is invincible. So in order for them to keep up the work they're doing, we need to be there for them and provide as much protection as we can for them as well as for anyone else. So what is paramount but what is often not available is the protective equipment. It is the availability of testing, and I'm very grateful to hear that there are strong efforts of the Noguchi Institute and Dr. Bonney to get the testing up. It is essential. Then leadership based on honest communication and not lies and not, making false statements of what we're facing. And then we need to support the mental health of frontline workers. They're extremely stressed. They're extremely stressed at work. They're extremely stressed in their home life. Kids are often out of school. There is no childcare. Access to food in the hospitals is often limited. Cafeterias are closed. There are not enough washing facilities because healthcare workers go home, hoping not to bring the virus to their families. And on top of it, as I said earlier, the frontline workers are often the only contact to COVID-19 patients, and and they're suffering tremendously, and having no family around puts a huge responsibility on those frontline workers. So they need help. They need understanding, they need help, they need practical support. Has that happened here in the US so far? no, it has not. There's been profound failure of leadership in the US as a whole, but also in many institutions. There has been a shortage of personal protective gear, and we still have insufficient testing capacity. In addition, there's been minimal practical support for the frontline workers. I've heard the saying a lot over the last 2-3 months: we are all in this together. Well, so this is a slide again from Johns Hopkins University, who are tracking the global confirmed cases. A slide I took off the website from last Friday, over 5 million confirmed cases and 350,000 global deaths. I highlighted here on the second slide the numbers that we got from Ghana. Were 6,500 confirmed cases as of last Friday and around 31 deaths. Now, I might ask you, are we really in this together? So from my point of view, we are so not all in this together, at least not in equal measures. So this little slide with a COVID-19 rate represents the city of Boston, where I happen to live. And these are the different neighborhoods. So you see the lighter pink, and then you see the darker purple. So how comes there are such discrepancies in reported cases per 10,000 residents? Well, let me tell you what we have learned that is going on in the purple areas. So the purple areas, you see one, for example, East Boston. It's an area where we have a lot of patients who had chronically limited access to healthcare, sometimes due to their immigration status. They're illegal in the country and they are afraid of seeking medical attention. So those patients' populations present with pre-existing diseases, and I mentioned some of them that puts them in a higher risk group: diabetes untreated, hypertension untreated, COPD. In addition, those areas of Boston, people live in very crowded circumstances. They often have to share very limited space with many other family and friends. They are often frontline workers. They work as cleaners. They work 2 jobs. They work in the food service. They use public transportation. So when you think about all of that, you might realize that it does not come as a surprise that the so-called hotspots in Boston, in the city of Boston, have been in those neighborhoods. And this is not because they don't know how to wash their hands. It's because of their low socioeconomic background and the living conditions and the history of untreated diseases. So I think each country and each region will have its own story. The BBC reported from 5 different countries in Africa. 5 BBC reporters put together a publication to assess where we stand in the different countries in Africa. And the question was raised: is the disease contained or is it unrecorded? And instead of a summary, I want to leave you with a citation by Desmond Tutu. A time of crisis is not just a time of anxiety and worry. It gives a chance, an opportunity to choose well or to choose badly. So I think it will all depend on all of us and on all our communities how we deal with this virus. And last but not least, a few key resources that I found helpful. So still the Center for Disease Control and Prevention, I do believe, is helpful. They are updating their website frequently. Then definitely the World Health Organization, now more independent from the US, which might be helpful. Johns Hopkins University, I showed you some slides from their website. Then the New England Journal of Medicine has made all publications about the coronavirus free of charge. And so you can access it freely without having to pay. And then myself, I do find the European Society of Intensive Care Medicine a very helpful resource. They have a blog, they have webinars, and they're updating their experience from a clinical point of view also frequently. So that's so far from my side. Thank you.
Thank you very much, Dr. Beutler. This is a very, very insightful presentation. We have gained a lot of insights, and I'm sure the clinicians among us will attest to many things that we have learned from this presentation. So at this point, we'll have the floor open for questions for panelists. Okay, so I go to Q&A. It's an anonymous attendee. The question is, does Madagascar's Artemisia extract tonic work, or is it just hocus pocus? So the question is whether this non-traditional, non-alternate approach to therapy coming from Artemisia species, whether it's real or it's just another story. I'll throw it to the panel, but before I do, I'm sure there's a lot more that we do not know. I haven't seen any data about this particular extract, but just like we are, there's a reversion to neem tree, and I guess Artemisia annua would be one of those. So there may be some anecdotal evidence, but I myself am not familiar with any concrete scientific studies establishing. And that is not to say that it's not effective. It's just that I haven't seen any direct evidence of its effectiveness. So Dr. Bonney and Dr. Beutler, I don't know what your
yeah, you are right, George. I mean, clearly we've not had any. Maybe we will not say that it doesn't work, because if it's not working for them, I think they wouldn't have brought it out there. But then again, you made a very important point. Do we have any scientific basis? Have they done any research work into it? Have they done any trials? Do we have any after effects of taking it and all that? We don't know so much about it. Herbal preparations or herbal concoctions that we use in this part of the world has its own place, and I know it is very important that some of them we take our time to do a proper investigation before we send it out there. Yes, it may work for some people, but it may also cause problems for others. So yes, they have a case. Maybe they have had some few people who have come out of it very well. And like example that you gave, the neem tree, people are using it all over the place, and they are coming out to say that it's working effectively. But then again, do we know what effect it has on other people? So it is important to have all these around us. I mean, we get herbs and from our great ancestors, that these are very good preparations that help in so many ailments. But have we researched, have we done a proper trial into it and come out with a proper medicine, or I mean the impact that it will have on such illness like COVID-19? So I think yes, it may be good for them, but it may not be good for everybody else, or even for their population. Not everybody may benefit from it. So I think it calls for further investigation into some of these things before we get latched onto them. So that is the bit I can say about that.
All right, so there have been a few follow-up questions. One of them simply says, so why don't we researchers go ahead and test it, clinical trials to see its efficacy? We can only know if we try. And another says, don't you think it's time to use already, this is Emmanuel Eduse, and the earlier one was from Dr. Kofi Vosa, and another anonymous attendee. Don't you think it's time to use already analyzed and registered herbal products or immune supplements at the various isolation centers in Ghana to generate the data and that we are talking about? So these are quick follow-up questions from the audience. Well, yeah, I mean, we can't know unless we try. But I guess this will have to come from among us as researchers. If we prioritize it, then we can pay attention to it and conduct proper studies to gather the data. I mean, I take it that if it's being used in Madagascar, it's being used in Ghana, and I think it's being used in other places as well. So I know there are institutions that are dedicated to doing plant medicine research, and there are pharmacognosicists and others who medicinal chemists who can dedicate some time to this. But as it is, we are talking about it. We have to be able to push it to those who make decisions on policy regarding this. Another question. Actually, there are a couple of other questions. Regarding viral load, I think Dr. Beutler or Dr. Bonney, regarding viral load, I'm thinking of practitioner and patient interactions in the consulting room. Is there a minimum or maximum time that increases the risk of exposure to the virus? That is, if I spend 10 minutes with a patient with the virus, is my risk lower than if I spend 30 minutes?
Well, so I would say it depends how you spend the time. If you can keep social distance, which we often can't as a physician, you're less likely of getting viral particles transmitted. If you're close to the patient examining his or her oropharynx, you're very likely to get some of the particles transmitted. So that would be my thought. It depends how you spend the time, not whether it's 10 or 30 minutes in regards to your exposure risk. Now, keep in mind, the reality is that many healthcare workers have been already infected and have been already through the disease and have recovered. So that's the good news. The bad news is that some of the healthcare workers, and we've seen a lot of publicity around that in the UK, have also gotten the disease very severely. So it may also, your risk of getting the disease and become symptomatic will probably also depend on your own age group, your own comorbidities, not only on viral transmission.
Okay. Thank you very much.
Just to add a little to it, I mean, if we talk about viral load with respect to somebody who is infectious and sitting right in front of you or very close to the person, I think we can talk about how prepared you are as against the person. If I talk about preparation, then I mean to say that, are you donning the right PPEs? Is the person also wearing a PPE? I mean, we can talk about, we talked about the N95 respirators or the face masks or even the face shield. Then again, we can also talk about the route of transmission. Is the person sneezing or coughing at that moment in time? So the force with which these aerosolized particles comes out and the distance that you are sharing with the person also come into play. So it all comes or boils down to the level of exposure that you will have when you have somebody sitting in front of you or interacting. So then you talk about the amount of inoculum of the virus that you will get from that person. So that also will come into play if we are to talk about the amount of, or we say the viral load. Will it have an effect of the person, or will it have an effect on you from a person who is infected and very close to you, or not? So that's the bit I want to add to it.
Okay, thank you very much, Dr. Bonney. We've had a statement from Professor Amoako in Nottingham that is not aware of any herbal medicine that has efficacy against coronaviruses. There are a number of questions. I'll probably just ask two of them at a time, just so that we can address them together. Has Ghana reached its peak, or should we prepare for the worst? Has Ghana reached its peak, or should we prepare for the worst? Another question: what is the turnover for testing COVID-19 at Noguchi? How long does it take for sampling to have having results ready, and how is the data collated to the public? I know there's also testing taking place at KCCR in Kumasi and at UHAS in Ho. I don't know which region it is in anymore, whether it's OT or Volta. There's so many changes. So we'll take those two now. Has Ghana reached its peak? How should we prepare, or should we prepare for the worst? What is the turnover for testing COVID-19 at Noguchi? How long does it take from sampling to having results ready, and how is this data collated for the public? And this is interesting given the thoughts shared by Dr. Beutler that the testing in and of itself alone may not be sufficient information to assess whether a person has the infection, looking at the Wuhan model that you shared. So, well, I'll leave the questions for the experts.
Okay, so let me talk about the peak and also Noguchi's testing turnover time. For peak, I mean, what we know from medical science is if we are to talk about a disease or epidemic or a pandemic for that matter has reached its peak, then you are looking at the number of cases, that is the new cases. That is, you are getting lesser new cases as against more recoveries. Then you can talk about, yes, now we are seeing a decline. But then if you talk about Ghana, because the question was directly referring to Ghana, if you look at daily case counts as against the number of recoveries, you don't see that trend. For now, you are not seeing that trend. So it will be difficult for you to clearly say that in Ghana, we have reached our peak. You look at the daily number of cases, that is the new cases we are getting, they far outnumber the number of recoveries that we see on a daily basis. So it's difficult for us to talk about, yes, we have maybe reached our peak. And for that matter, we are now declining with the cases of infections that we are getting with regards to the COVID-19. Then about the Noguchi's turnover time with regards to the testing. For now, what we do is we are receiving a lot of clinical specimen from all over. Even though we have other places in the country testing, Noguchi is the largest testing center. In fact, if you look at the statistics, we've tested about close to about 80% of all the cases that we've had, and we're still doing that. What happens is, if you look at the surveillance system that we have in place currently, they are bringing in what we call the hospital cases or the suspected cases. Those who walk in or those who directly call medical staff to take specimens from them. Then we are also doing the case contact tracing. So the contact tracing cases are quite a lot. on a daily basis, we can get close to 2,000 on the average from contact tracing. But the hospital cases or the suspected cases are not so much. And these are people who probably may be going through a hospital procedure and they want to rule out COVID-19. So what we do as a testing center is when we get those hospital cases, because they are not many, we tend to finish within 24 hours, at most 48 hours, the results will go out there. But with the contact tracing, it takes about 3 days because of the numbers. It doesn't mean that we give priority to any of them. We work hand in hand with both clinical specimen. But because of the numbers, the sheer numbers of the the contact tracing cases, it tends to go to about 2 or 3 days. So if you talk about our turnaround time, we are looking at 3 days, 2 days mainly for those hospital cases and 3 days, maximum a week for the contact tracing cases that we have.
All right, thank you very much. Let me just lump together a few additional questions. The question about time spent with patients, the Dr. Enyam Komla Ameuho actually says, to provide better context, I'm an optometrist working in a hospital setting, And then let me ask a few follow-up questions. Dr. Bonney was reported in the media to have said that Ghana lifted its lockdown too early. Is it true, and why is it too early? And more generally, I don't know, Dr. Beutler may be able to address this. Since N95 masks are hard to come by, even for healthcare workers, are cloth masks completely useless? Are cloth masks completely useless?
Well, so I mean, I really sympathize with the person who posted the question, because we've been in a similar situation here, not having a N95 mask when we thought it was needed. So the next best is probably a surgical mask, because it has a little bit more of a filter in it than true cloth. There are different models even for the cloth mask, whether that's a double layer, whether you put another filter in. There's a lot put out on the internet. The bottom line is you need to try to keep as much distance from a patient, as Dr. Bonney said, who's coughing, who has COVID, to avoid the transmission. Now, another part that can be helpful is a face shield. So people have even made their own face shields out of simple plastic. So if you can wear a face shield in addition to a mask, that might be very helpful. So we have also our face shields, we needed to clean. You can clean them with soap. It's clear plastic. If you can cover that so that the transmission, any particles, at least some of them are held up by the plastic shield, even that might be helpful. And I would do that if you can. Even maybe more important than a cloth mask, because that would probably not prevent the viruses from being transmitted. But a face shield, if you can do a long one, we've done them like from here, the whole face, and you clean them with soap after a patient contact, that may be the best bet. So there have been N95 masks here invented by some of my colleagues because we didn't have them. So it is a very difficult problem, but you need to try to create a barrier. And a cloth mask itself will probably not do that. You need something else. And maybe plastic as a face shield might be the next best bet.
So does that suggest that those of us working in groceries with cloth masks, it's just we only have a false sense of security doing that?
Well, we probably have, but in that regard, it may help. So the coughing, so someone who wears it, it may decrease the chances of them spreading the virus by coughing onto the food, you know, or surfaces, or directly on someone else. But the cloth face mask and even a surgical mask will not prevent you from getting the virus yourself. So there is a value to it in the community, to wear them at times when you are out, but in the healthcare setting, it will not prevent the provider from getting infected.
Okay. Thank you very much. Dr. Bonney, your statements in the press.
Yes, before I get to the press question that you had for me, with the cloth masks that you're talking about, yes, in fact, I like what Dr. Beutler said, and she was right on point. I mean, the idea is to prevent droplets. We are talking about droplet infection. So if you have any kind of protection or a barrier that helps you to prevent droplets, it helps. It's not totally useless. It has its own place. I think it helps. If you are wearing the cloth mask, one, you yourself, you prevent, I mean, it helps you to prevent droplets all over the place. And also, if you are coughing or sneezing and somebody's out, you are holding it back. So if there are any aerosolized particles inside there, you are just holding it back. So in that aspect or in that respect, I think it is not a bad option. But sometimes it's the way people use them, the way they use them, they tend to even infect themselves because of the duration that they use and how they handle it and all that. So that aspect, I think education has to go in there for people to understand how to use it properly, because it's now all over the place. Every tailor or seamstress is sewing and selling. And sometimes the kind of fabric that they use to make is also even questionable. It helps you, it can stop you from breathing well and all that. So yes, it will help you to hold droplets from all over, I mean, spreading on formats and all that. But we have to be careful how we use it, because it has a good size and it's a bad size, I should say. On the question of the media, I think maybe it may have been a misrepresentation of what I said. We were talking, I think there was a question on whether we should have gone on with the partial lockdown we had. And I think I quite remember that I answered yes, it was partial. And in so many places of the country, we were not actually observing even the partial lockdown. For all we know about this disease, the best option is to stay at home. See, because the moment you move with the disease. So when we got to the stage where the country declared partial lockdown in the two main cities, it helped in so many ways. In fact, we have had evidence from so many countries across the globe that the best option is a total lockdown. But because of our economic situation, we couldn't have gone through that, because yes, people were struggling for the few maybe weeks that we had. People were struggling, not only the fear of the disease, but the trauma that they were going through of even being at home and how they would come about. I mean, their daily bread was an issue. So yes, we had a partial lockdown. If we had extended it from the public health perspective, it would have been good for us as a country, because the more you stay at home or the more you stop mingling with others in public places, the more you tend to stop the spread of the virus. It is a respiratory virus and it spreads very fast. But then as you mingle or you go out there with so many people without any protection, then we can guarantee that it's going to spread. Mind you, we have a lot of asymptomatics also in place there, out there. Before somebody becomes severely sick, the person might have started shedding the virus before it becomes clinically ill or because you can see the signs. So then it is the best for us to stay at home or to try and go through that lockdown for a longer period and make sure that we do the tracing and testing before we maybe either ease the restrictions or allow everybody to come out there. So I think that was what I was trying to explain. I've not read the newspaper article, but from what you said, I guess that was what was written. And I'm saying this because of what I said. I mean, I'm trying to explain what I said. So, I mean, that is it for now. If there are any more questions on that, I'll try and...
Okay, so there are a few comments and questions. There's the audience comments expressing appreciation for the excellent and informative presentations from the panelists. The other question is cash transactions. Whether or not cash transactions will help. How does exchange of cash influence community transmission since businesses have now been reopened in Ghana? And then there's also a question as to whether there's been a study that supports the assertion that, let me read the question itself. May I know whether there's any study that supports Dr. Sascha's position on the 3-layered cloth mask as approved by the FDA?
No, the FDA hasn't approved anything
Okay.
in regards to cloth masks. So, and what I referred to was the recommendation to do 2 layers, and then there's the idea of putting potentially a filter in the 2-layer. But there's nothing being approved. These are all people scrambling to try to find something that may help. So I may make it. So I wanted to mention one country that has taken a totally different approach, and I think it's just a country that we should be watching, is Sweden. So Sweden has never had a true lockdown, and they have taken a very different approach. They're counting on the virus to spread throughout the society and creating immunity. Now, the jury on this approach is still out. It appears, not surprisingly, that vulnerable population in Sweden, so those in long-term care facilities, in elderly homes, are hard hit. And there have been many deaths reported in that population within the Swedish society. But I think it's a different approach that we need to watch, because with the lockdown, even in the US, we have not been successful, and we have created huge problems in the education sector that will have implications for this next generation and will worsen the inequalities, because there are many kids who have even worse access now to education. We've also created a population which has an even higher unemployment, which is a huge problem for the society. So the jury on the success of lockdowns is still out. And the only thing that we have achieved, very importantly though, is to slow down the spread of the disease, not to overwhelm the healthcare systems. But we have not yet, but at a big price. And so I think we need to look at other countries who've taken different approaches to see how that is working out there.
Yeah, so that's very interesting. That's a very interesting observation, because I looked at the purple sections of the map you showed, and that's pretty much the story of many communities around the world. There are places in Ghana where, there are extended families. You can have 10 people share a room. Nobody sleeps inside. They just keep their precious belongings in there, and everybody sleeps outside, so to speak. So there are issues with access to care and the practicality of locking down, because really, sometimes there's really no door to be locked. So that's the other viewpoint, and the question of herd immunity is very interesting because even with the lockdown, there's going to be some level of that. Some quick studies people have done in certain localities in the United States show that a significant portions of the population already have the virus, but are asymptomatic. What about your thoughts on cash transactions? Is that going to?
WHO just kind of reworded their concerns of transmission from surfaces, no? And let's consider cash a surface.
Yeah.
So from SARS, the thought was that surfaces could transmit the virus for 3 days, and Dr. Bonney may step in, he's the expert. But it appears now that the weight on surfaces or the chances of transmission from surfaces is not as high as first feared. So the way I look at it, and what is most important, is to wash hands. Now, I know this can be in itself a challenge, but to avoid, when you've been out and you have touched cash, you've done your shopping, you've touched all surfaces, you need to try to avoid touching your face and your nose, because then you might have virus particles on the hands and transmitting it to yourself, which is very hard to avoid. We all are touching our faces frequently. And wash hands before you come home. Wash hands if you have an opportunity in between. So hand washing, I think, is here the way to go, with cash and other things that you touch along the way.
Thank you very much. Yeah, that is the hands and the washing. Yesterday I was at Home Depot, and my son and I helped a lady with a load that she couldn't carry, and then she shook my hands. I mean, she stretched her hands and it was hard to not. So, we had to, as quickly as we could, use a hand sanitizer. Of course, when she had left the scene. Yeah, so I don't know whether this will affect our cultural traditions, the shaking of hands at funerals. There's so many things that are changing as a consequence. There's one observation someone made. I don't think it's a question. There should be a collaboration between Noguchi and the Center for Plant Medicine Research to carry out, this is from Emmanuel Edusai, to carry out in vitro studies on potential herbal medicines submitted by practitioners at the request of the Ministry of Health. This will help select products or medicines for trial at the isolation centers to generate clinical data. So I don't think it's a question, but it's an observation that I don't know if Dr. Bonney, you like.
Yeah, I mean, there's already something in place. I mean, we are working towards that. We've had collaborations with them in different fronts over the years. So there's not a new thing. We've during HIV, we did a lot of work together with some plant extracts from them that were very good markets. We are also started writing and all that. So we have plans, because we have started now isolating the virus in cell culture. So we have plans to do further work with the virus and with institutions like CSIR.
Thank you very much. Thank you very much. So I think we've addressed several questions, and at this point, again, I'd like to echo the sentiments expressed by several in the audience. This has been a very enlightening time spent with Dr. Beutler and Dr. Bonney. I don't know if you have any closing thoughts before we end the session for our panelists.
So all that I have to say is that I'll have to thank you and the organizers for such opportunity. I think we need to do more of this so that more the information will go out there for people to really know that, yes, it is not a fluke. I mean, what we are dealing with is a real deadly virus. Yes, we in some places like Ghana, our mortality rate is quite low, and that is means somebody is doing some good work out there. That's why we are seeing that. That one is debatable, but that's what I think. But people here, there are so many people around that still do not believe that it's real, and that is the danger. So I always call for more education. Platforms like this and other platforms can be used to educate people, to let people know that, yes, we are dealing with a pandemic that has the potential to cause a lot of people, a lot of problems. So we should beware and take the necessary precautions. All the protocols that are out there should be adhered to strictly, because if we don't do that, it may get out of hand and the consequences will be very difficult for us to bear. So these are my closing thoughts, really. Thank you.
Thank you very much, Dr. Bonney. Dr. Beutler?
Yeah, I think Dr. Bonney summarized it well, and pointed out that education and communication are key, because the situation is evolving. We need honest leadership. This is probably the hardest to come by, because often leaders want not to state the reality, but without that type of honesty, we cannot work on the solutions. But it also means to be honest about what can be done in an individual or in a certain community. As Dr. Aquamenza pointed out, a lockdown when there is no lock to the door is not the solution. So we really have to think about what is feasible and possible, and where do our communities need support. So we need to find a whole different approach to supporting each other in our society. And then we might be all in it together, which we are not at this point.
Thank you very much for the closing thoughts. And thank you all. Thanks so much for the time. The recording of this session will be on the website and be available on demand. And thank you so much. And it's yet early morning here in Boston, Massachusetts, and so I say good morning and good afternoon for those of you on the other side of the meridian. Thank you all. Thanks. Bye-bye. Bye.